So we've got a case of a 1-year-old girl who presents to the emergency department with meningococcal sepsis. So a very short history of being unwell, pyrexia, out of form, and then this puperic rash, which is spreading in front of your eyes. So initial assessment on presentation to the emergency department, the airway is patent. She's tachypneic with a respiratory rate of 55 per minute, but the chest sounds clear and saturating nicely at 100% on a non-rebreather. Circulation is a bit of a worry. Tachycardic at 198, capreethal centrally 6 seconds, and a really quite worrying sign, a peri-arrest sign, hypotension of 55/28. She's really shut down, cool peripheries all the way up to the trunk, and you can't feel any of the peripheral pulses. Still responsive to voice, pupils are equal and reactive, and blood sugar's a little bit high as she's stressed. And she is pyrexic, and you've got this spreading puperic rash in front of your eyes. So in terms of the initial management, you're going to want to call for help because this patient has a really quite a high mortality rate if you don't do things right. You go ahead and get 2 ports of access. You manage to get 1 IV line. Access is proving difficulty, so you go ahead and put an IO in. So you've got 1 IV and 1 IO, and you send off your standard meningococcal pack of bloods. One slight modification, rather than just sending in a group and save, you actually decide you're going to go and cross-match products. Because you've done quite a bit, you've looked after a few of these kids before, and you know you're almost certainly going to give them products, and that would be something I would encourage you to do. Get blood products ready, because the last thing you want to do is keep filling these patients full of clear, useless fluid when actually you can give them something helpful later on. You go ahead and you resuscitate them, so they get 2 10 ml per kilo fluid boluses over the first 10 minutes. You give them some appropriate antibiotics, so that would either be ceftriaxone or cefotaxime. And I suppose the first question for the guys in the panel, any preference about what you would give?
With regards to clear fluid, is that?
Sorry, the antibiotics,
Oh, sorry.
cefotaxime or ceftriaxone.
Ceftriaxone is probably what I would go for, personally. Um,
Yeah, and I think that's very common in Northern Ireland, because it's their standard knee-jerk response. The difficulty is that ceftriaxone is going to have to be given over 30 minutes as an infusion, and you've worked so hard to get those 2 precious IV lines. And for me, I would much rather give a bolus of cefotaxime and free that line up for the other important drugs that you're going to want to give. The other potential problem you might have is with calcium administration. Quite often you're going to want to give these kids calcium earlier on, and you can't give them calcium while you're running ceftriaxone. So personally, I would give cefotaxime for those reasons. The advantages of ceftriaxone are really just once daily administration. And I think a bolus of cefotaxime 6 hours later, start the ceftriaxone, you've got all your lines to get the advantages from it. And then we go on ahead and reassess our patient. So you've got your gas back by this stage, and it's not pretty. pH is 7.18. We're okay from a respiratory point of view, but there is a really significant metabolic acidosis, and our lactate's making up most of that at 9.8. Hemoglobin's okay at the moment. Sodium, potassium okay, but our calcium is actually low. So you go ahead and actually reassess them after that first fluid bolus, and they haven't really improved. Cap refill still 6 seconds, still tachycardic, still hypotensive. So again, you push in another 2 10 ml per kilo fluid boluses. You decide to give the cefotaxime, but because the calcium's low, it allows you to give some calcium gluconate at the same time. After 40 mils per kilo of fluid, again, things really haven't improved. In fact, they're maybe a little bit worse, with a cap refill of 7 seconds, heart rate's increased to 199, and blood pressure's 50/26. So what do we need to do now? And this is over to you guys again. What do you think?
Suppose a few things, Chris. First, if we called for help earlier, I'm not sure exactly who we're called, but at this stage I'm going to be talking to ICU, intensivists and calling anaesthetics. I suppose other things you'd be wanting to think about would be use of products rather than fluids, and whether we're going to need any inotropic support. So I suppose that's a few of the things maybe we'd be thinking about at this stage.
Yeah, so all really good considerations. In terms of who you're going to want involved, you're definitely going to want consultant level support. If you're in the emergency department, the ED consultant, you're probably going to want the paediatric consultant as well to be involved. And like you say, somebody from either anaesthetics or intensive care. And when I find myself in this position, there's 40 mils per kilo of fluid in. You have to remember the child's circulating volume is 80 mils per kilo. So very rapidly, you've replaced half their circulating volume. So at this stage, you should have resuscitated them from a fluid point of view. And if that fluid hasn't worked, you've got fluid refractory shock. So for me in this stage, there's three things you need to do. You need to give them some more fluid. And this is the reason why you say, if you have products available, it makes sense to use sensible things. Probably at this stage at 20 minutes in, they're still not available, so you might have to give crystalloid, but you're going to try and give the products when they come. You're going to want to start vasoactive drugs, and you're going to want to semi-electively intubate and ventilate the patient. So in terms of intubation and ventilation, why are we doing that? Our patients' oxygen levels are good. They're saturating nicely. They're a wee bit tachypneic. Why are we doing an airway and breathing intervention for a circulation problem?
So you're going to be giving significant amount of fluid to these children, which can lead to pulmonary edema as you go down the line. So you're going to be wanting to ventilate them to help protect their lungs a little bit, but you're also going to need to get central access and art lines in, which is a painful procedure, is much easier to do when the patient is intubated and paralyzed. And then you can give your inotropes and your fluids through that and products through that. And then it makes it also more comfortable for the child, but it also reduces their metabolic demand. And I think that they're not moving, they're not stressed. It helps to manage them better, but also reduce their oxygen requirements and metabolic demand. Those are my key points.
They're absolutely perfect. And I think the third one is probably the big one, isn't it? Peter's showing that equation earlier on for oxygen delivery, and we'll come on to talk about it a wee bit later on. But the big issue is we're struggling to deliver oxygen to the tissues. That's what shock is. And what we can do is we'll try and optimize and we'll try and deliver oxygen as best we can to this patient. But the big thing that we can do is actually reduce this patient's demand for oxygen. So by putting them on the ventilator, we can, that cardiac output that was going to those muscles of respiration and the kids breathing away at 50, it's a reasonable amount of the cardiac output. We can use that to perfuse the vital organs. By going to sleep and putting sedation on, maybe trying to get that temperature down a little bit, all that demand for oxygen is going to go down, and hopefully then the patient will manage with a slightly reduced supply. So that's our goals. And in terms of how we're going to do that, we're going to have to resuscitate this kid before we intubate them. Because if we try and intubate them now in this shocked state, they're very highly likely to arrest. We're not going to ignore the airway. They're quite tachypneic, and we're going to want to pre-oxygenate them. So we can put them onto a breathing circuit, give them a little bit of PEEP, and take away a bit of that work of breathing, get them pre-oxygenated and prepared for intubation while plans are going on in the background. In terms of the drugs, we're going to use adrenaline as our first line vasoactive drug. Anybody want to cover how we're going to make that up?
For peripheral adrenaline,
Peripheral, yeah.
I suppose 1 milligram and 50 mils is sort of what I'm familiar with.
And do you know what rate you start that at, Stephen?
Well, we want to run it at 0.1 units per kilo to start with, I think, but I would need to double check rates.
And that's the thing. You've got all your resources there. You've got the apps, places have printouts. So you're right, it's easy to make up. It's 1 milligram and 50 mils, and you take the child's weight, which is 10 kilos in our case, multiply it by 0.3, and that's then going to give you your rate of administration. So for our child, it would be 3 mils an hour, and that gives you 0.1 mics per kilo per minute. That dose of adrenaline is going to provide vasoconstriction and inotropy, and that's what we're going to want for our child, because we're going to want to support their heart. We haven't performed a point of care echo, and that may be something that's not going to be done in the DGH, so we assume there's going to be some myocardial dysfunction. We probably want to squeeze the afterload, so that dose is going to do both of those things, and that's why we pick that, and then we're going to titrate that to effect. There is a few important things you have to remember when starting that adrenaline infusion. Can you give me any of those?
It's important to consider your dead space, and that's just in your cannula and also in your extension set. So roughly working out when the patient is going to be able to actually get that dose of adrenaline.
Yep. And it's quite scary, isn't it? How long it can take to administer adrenaline to patients. I think in the example that I've used, if we were to start this on a 3 kilo patient, so running at 0.9 mils an hour, to get through the standard dead space, 0.1 mils for cannula, 0.3 mils for connector, it would take 27 minutes. So one common mistake people make is they'll start this, it'll be running, the patient hasn't received it, and they go ahead and induce anesthesia, and then the patient arrests because there wasn't adrenaline in the circulation. So there's a few ways to combat that. One, you can take the little connector, flush it through with the adrenaline solution, so you're taking away the majority of the dead space. You've only got the dead space of the cannula to start. Other people will start at a slightly higher rate, wait for the adrenaline to hit the patient. You'll see that by the heart rate and blood pressure going up, and then maybe pulling that dose back. But you're definitely going to want to make sure your patient has adrenaline in the circulation before you induce anesthesia. So that's the little diagram with the cannula. If you don't know what they are, hopefully on the back of the packaging, it'll give you some information about the dead space. Or you can simply take a 1 ml syringe full of saline, flush it through, and see how long it takes for it to come out at the end of the cannula, and then save that number away. What about push dose adrenaline? How do we make that up?
It would be 1 mil of 1 in 10,000 into 9 mils of saline.
Yep, so we're effectively taking our arrest dose of adrenaline and we're diluting it down by a factor of 10. And how much do we give in that in terms of mils?
Roughly 0.1 mil per kilogram, a maximum of about 2 mils.
Yeah, perfect. So you're given the same dose that you would give in a cardiac arrest in terms of mils, but because you've already reduced it by 10, it's going to be a tenth of that dose. So it's a little bit of adrenaline, tenth of what you give in a cardiac arrest, but it's still a pretty high dose compared to an infusion. If you had to pick between one of the two of them for our patient, which would you go for? So remember, our patient's hypotensive.
I would probably be greedy, Chris, and I would have both ready. I would certainly have the adrenaline infusion attached, but I might give a bit of push dose adrenaline that would work while I was waiting for the adrenaline to get through the dead space in my cannula.
Yeah, and I think that's exactly what I would do as well. The question I ask myself is, do I think my patient's at risk of arresting by the time I get my adrenaline infusion made up, connected through the dead space and reach the patient and titrated to effect? And if the answer is yes, I would give them some push dose adrenaline while that is happening. So I think for our patient, we know that hypotension is a peri-arrest sign, so we're very definitely going to want to start, I think, with that push dose adrenaline while we're getting our adrenaline infusion titrated to effect. So then we come on to intubating our patient. Is there anything in particular we need to take into account when we're intubating them? What would be our plan and what would be the risks?
Just from an overall point of view, there's key communication that you need to give with your team here. This, as you've already said, is a peri-arrest patient, and you're just about to give them anesthetic agents that might, will in this circumstance, give further cardiovascular compromise. Even if you use drugs such as ketamine that is thought to be a bit more protective, their catecholamines are just all over the place at the minute and probably used up. So communication with the team that there's a high chance of arrest would be one of my priorities. I'm sure others will have other ideas as well, but you have to be ready for cardiac arrest. You have to have your fluid boluses ready. You have to have your adrenaline ready and running prior to starting this intubation.
Thanks, great points, Tudor. Anybody else have anything?
I would also say this is not the moment for your trainee to have their first go at putting a tube in. You need somebody, your best go needs to be your first go. And you need somebody experienced to be doing that.
Yep, definitely. Anything else? What about how are we going to detect that our patient is deteriorated, and what are we going to do about it?
Have constant blood pressure monitoring, and then somebody else having their finger on the pulse, and then they're going to give push dose adrenaline if the pulse, if they note that it's decreasing. to be on top of it throughout.
Yeah, absolutely. The blood pressure, one, is too slow. Even if you have it cycling every minute, the problem is when that blood pressure drops, the cuff is going to try and find the blood pressure. It won't find it, so it'll try again and it'll try again, and then your patient will have arrested before you've realised. What we're going to do with our patient is we're going to resuscitate them to where we get them to a stable point. If somebody pops a finger on a pulse at that point and feels what the pulse feels like when we're happy with the patient, they get that sort of baseline. And then if that disappears, rather than waiting, they're just going to give that push dose adrenaline to bring the patient up, because pushing fluids in this situation is just going to be too slow. What about our drugs? What drugs are we going to use for intubation?
We would consider things like ketamine, just from a cardiovascular stability perspective, but bearing in mind that there's still a high risk of cardiac arrest, even with the drugs used at lower doses. Consider such things as muscle relaxants such as rocuronium, and I'd be avoiding propofol in this situation due to the potential for further hypotension leading to arrest.
Yeah, 100%. And what dose of ketamine?
So probably 0.5 milligrams per kilogram, but potentially even less, 0.25 milligrams per kilogram, just with how incredibly sick the patient is. Just kind of thinking I can give more if it's required.
Yeah, I've never in my life had to give one of these patients more. They go out like a light, and the moment they go out, their blood pressure just disappears. So yeah, you have to be ready for it. I tend to use a half per kilo, 1 per kilo of rock with it. But these patients will go out with that. They've never ever had to give them more.
Sometimes it takes them a little bit longer to go out because of their low cardiac output, and you have to be patient and not be tempted to give a second dose while you're waiting for that first dose to work.
So I'll run through the slides. I think we've probably covered most of this. So we've got finger on the pulse because the blood pressure is going to be too slow. No propofol, ketamine and rock. You might want to have some resuscitation drugs prepared as well, or you definitely will. Cuff tubes, but that's now standard practice. It wasn't when I was preparing this talk originally. And whatever you do, don't put that tube down the nose because they're coagulopathic and thrombocytopenic, and the last thing you need to do is create more problems. Okay, so let's look at what happens to our patients. So we go ahead and give them another 20 mils per kilo of fluid, so 60 mils in total. Where our peripheral adrenaline, we titrate up from that 0.1 to 0.3 mics per kilo per minute, so a really good pressor dose of adrenaline. With that, we do get a bit of stability, so heart rate comes down to 170, blood pressure comes up, and cap refill returns to 5 seconds. So we feel we've got a window to get this patient intubated. We do a modified RSI, half per kilo ketamine, 1 per kilo rock, but they do bottom out their blood pressure during this. They need 3 boluses of push dose adrenaline, and we're having to put the adrenaline infusion up to 0.5 mics per kilo per minute during the intubation. So we go ahead and reassess them after the intubation, and putting the tube down was straightforward, and that's quite often the bit that is straightforward. The intubation is normally easy. It's keeping the patient alive during the intubation. That's the hard bit. So we'll appropriately sized cuff tube in a good position on our chest x-ray. We go into standard settings on the ventilator, and we repeat our blood gas. So still acidotic, it's not respiratory, it's all metabolic, and our lactate is actually higher than what it was before. So we're not clearing our lactate. Our hemoglobin has dropped to 89. Not a big surprise. We've diluted things down with 60 mils per kilo of fluid. Salts are still okay. And despite 1 calcium top up, our calcium's dropped again. So why is our calcium so important? Why am I focusing a little bit on it?
It's because your inotropes work on myocardial contractility, and you need calcium to sort of facilitate that. So without adequate calcium, your inotropes aren't really going to do the job you're looking for them to do.
Exactly. They all increase intercellular calcium. If you've got no calcium, they can't increase it, so they're not going to work. We get our central line, north line in. We move our adrenaline over to the central line. Importantly, you're going to want to double pump it over. You can't just stop it. But we're still not winning. We're tachycardic again. Blood pressure's dropped. Cap refill's back to 7 seconds. We can't feel our peripheral pulses. Our CVP is low at 6. It's a neckline in a ventilated patient. It should be a little bit higher than that. And probably the most worrying sign is our venous sats are quite incredibly low at 34%. And our lactate's elevated as well. We go into standard sedation. Blood sugar remains a little bit high, but we're not going to do anything about that. And we get our bloods back, and not a big surprise looking at the bloods. Our hemoglobin matches what's happened on the gas. White cells are up, platelets are low. We're coagulopathic with a prolonged PT, APTT, and low fibrinogen. Renal function's not too bad. Calcium, albumin, and CRP is elevated as well. So our calcium's telling us what our gas has already done, and we're sort of looking into the past at this stage. We put our patient up on 2/3 maintenance fluids, and we get our bladder catheterized, NG tube in, and we've already given our antibiotics. So we want to take a look at, are we meeting all the goals that we want for our patients? So if we take a look, have we normalized the heart rate? No. Have we increased our CVP to an appropriate level? No. Have we got a normal blood pressure for age? No. Have we cleared our lactate? No, it's still increasing. And you can see we're normally aiming for mixed venous oxygen saturations greater than 70, so they're incredibly low. Cap refill hasn't improved. We don't have normal pulse volume. Our peripheries are freezing, and we're not sure about the urine outputs. The catheter's only just in, but there's not very much urine in the bladder. So we're not really doing a great job with this patient at the moment. So this is where Peter's already talked about this formula for delivery of oxygen to the tissues. Our patient has a problem with oxygen delivery. We've done our best to reduce the extraction of oxygen so we can get away with a minimal supply by taking over the work of the muscles of respiration and putting our patient to sleep. And certainly if we can try and get that temperature down a little bit, that's going to help as well. But we want to improve our delivery of oxygen to the tissues. And Peter's showing you the nice complex formula. What I tend to do with this formula, I don't tell Peter, is put a line through it and just look at the variables. And the variables are hemoglobin, saturation, and cardiac output. And these are the variables that are going to determine whether you deliver oxygen to your tissues or not. So in terms of our hemoglobin, what do you guys think of the hemoglobin?
It could definitely be optimized. We could definitely give packed red cells and try and push that up to 100 or even above 100.
Yep, so that would be our target, above 100 when you're struggling to deliver oxygen. And the idea is if you've got more hemoglobin molecules going round, even though the pump's not moving them particularly well, you're going to have more molecules that the tissues can strip oxygen off. We're already saturated at 100%, so we can't do anything with that. But the other big potential problem is our cardiac output. So we're going to need to take a look at that and see what we need to do here. So I like to break this up into, there's the tank. You have to decide, do I need to put more fluid into the tank? There's a pump. Do I need to decide if I need to do anything with the pump? And there's the pipes. So we either sometimes need to squeeze the pipes, but other times we need to dilate them. Because you have to remember, the big thing you're interested in is not blood pressure, it's flow and flow to the major organs. So in terms of how we're going to decide if we need to do fluid, there's three major things I tend to look at. We've got our CVP, which is a little bit on the low side. If this is our patient's arterial line, what do you think of it? Is any signs that our patient needs fluid?
Yes, there's a swing in the outline. It's not coming, it's not all static.
Yeah, there's a very significant swing, isn't there? I tend to think if it's more than 10%, I would call it significant. And that's quite a big swing. So CVP being low tells us probably give fluid. Swing in the outline, probably give fluid. And when we do our point of care ultrasound, there's a bit of debate whether it's useful in trauma. It's very useful for our medical patients. This is our patient over the right-hand side. We're looking at the IVC. So what do you think of that IVC? We've got a normal one on the left-hand side.
Very collapsible.
It is. So with respirations, it's collapsing. So there's three things that are telling us we probably should give our patient more fluid. And why are we having to give them more fluid? Sure, we put 60 mils per kilo into a circulation that normally has 80 mils per kilo.
Vasodilatory condition, and there's capillary leak.
Yeah, they're the two big things. So they could be dilated, but the big one is that leak of the tissues out. And what you tend to have to do, sometimes you're giving these patients hundreds of mils per kilo over the first 24 hours. It's that the bolus helps for a wee while, it stays in the circulation, it leaks out, and then you have to give more. And you're just trying to buy yourself time for things to get better. But certainly looking at this, our patient probably would benefit from some more fluid. In terms of the function, we're going to put the echo probe on. What do we think? Do we need to do anything with this? We're on 0.5 of adrenaline. No, it looks fairly normal, doesn't it? It's not hyperdynamic, but there's certainly the cardiac function looks good. So the 0.5 of adrenaline is doing its job. And in terms of the afterload, you can do all sorts of fancy cardiac output monitoring, but I think the simplest thing to do in the DGH is look at the pulse pressure. Your difference between your systolic and diastolic pressure. If there's a really big difference between the two, you probably want to squeeze things. If they're too close together, you might actually want to dilate things. So that would be how I would look at the afterload. I think it's helpful to put our patient into one of these groups, and it helps decide what drugs you're probably going to want to use. So our patient has low blood pressure, and do they have cold or warm shock?
A cold shock.
They're cold shock. So if we look here, we've already started with our adrenaline. The next thing to add would be noradrenaline. We're on a pressor dose of adrenaline. It's not working, so we probably want to think about some noradrenaline. So in terms of our progress for our patient, we go ahead, thankfully we have cross-matched those products right at the start. So we're able to optimize our oxygen delivery by giving some blood. And obviously this is going to work as a fluid bolus as well. We give some FFP, cryo and platelets. So we're able to resuscitate our patient with useful fluids. And a lot of these problems we've exacerbated by the amount of clear fluid we've had to give initially. We start some noradrenaline, titrated up from the normal starting dose of 0.1 to quite a big dose, 0.6 mics per kilo per minute. But this makes no improvement to our patient. So why aren't the vasoactive drugs working?
Did we ever fix the calcium?
We did, but that's a very good point. So if the calcium had dropped again, we probably need to fix it. What else?
I suppose we need to consider the lines they're going through. Are we happy that the lines and they're actually getting the drugs delivered to their body?
100%. So we check the line, it aspirates beautifully from another lumen. We've got a normal CVP trace, so we're happy with the lines.
Well, an awful pH, so it doesn't work. The drugs are not working.
100% could be pH. Any other ones? I have a big list on the next page, so if you can get a couple more. What else? The DGH has made these drugs up.
Are they made up correctly? Are they the concentration that you're expecting?
So there's always a risk, isn't there, when somebody's making up a drug or a treatment that they don't normally use, has it been done correctly? And that's one of the things you're going to, well, first things we go out is what's in the syringe, what's it running at, and do the calculations ourselves. So I'll go on to the next page. So we got the line. Dead space should be sorted by this stage. Errors, pH, calcium. Have we picked the wrong choice? Steroids we haven't mentioned. And normally we come in to think about relative adrenal insufficiency when we're on 2 vasoactive drugs and they're not working. What do we mean by relative adrenal insufficiency? Is this patient, is their cortisol production low?
Their cortisol production is probably high, but it's the fact they're sort of consuming those catecholamines that they naturally produce. So they've got a relative deficiency, not an absolute.
That's it. So you've got to, normally as your stress goes up, your cortisol production goes up and they tend to match. In this overwhelming sepsis, your stress is here. The best your body can do with cortisol is here. So you've got a relative deficiency. So what you want to do is add some low dose hydrocortisone in to try and sort of bridge that gap. You don't want to do high dose where you're going to suppress the immune system because the studies have shown that increases mortality. And then you're going to want to think, have I got the right diagnosis? I'll not go through all this, but there's a list of other things on the side you might want to consider. I think it's very clear in our case that we have got meningococcal sepsis, but we might want to put the echo probe on and make sure we haven't developed a pericardial effusion, we haven't popped a pneumothorax, or we're not developing one of these other mechanical causes of shock. So we go ahead and give some more hydrocortisone, some calcium and some bicarb, and again be careful you're not giving the calcium and the bicarb straight after each other in the same line without a good flush because they don't mix particularly well. And we reassess our patient. So A and B are pretty much unchanged. We're ventilating quite nicely on not a lot of oxygen. Our adrenaline's still running at 0.5. The NORAD sneaked up to 0.6. Heart rate's still up, blood pressure now has been a bit of a change, is up at 98/74, and our cap refill is 6 seconds. We're still shut down. CVP's increased up to 18 from 6, and our venous sats are still low at 36. Nothing's really changed with D. And in terms of our gas, we have fixed our calcium, we have fixed our hemoglobin, but our lactate is still high. So what now?
Your blood pressure has improved a lot. The patient's still very tachycardic. But your venous sats are still low.
What do you think of the blood pressure in terms of the pulse pressure?
It's a bit too good and it's a bit narrow. So I think you might be overdoing your vasopressors a bit.
Yeah, and what does the CVP? The CVP sort of telling us the same thing, isn't it?
Yeah, and they're well filled. You can sort of get an idea of that from the CVP now.
Why have our drugs suddenly started working?
Could be any of the 3 things that you did on the last slide.
Yep, definitely. So and this is what happens to these patients. They flip from one type of shock to another. So at any 1 minute, the treatment that you're giving, which is correct, is completely wrong. So this is all telling us we're on too much pressure, we're squeezing too hard, and we're not getting flow out to our organs. So what do we need to do about it? Should we add in, if we look up at our graph, we're now in high blood pressure cold shock, and it's telling us to begin some milrinone.
I might get it made up, but I would probably start with trying to wean that adrenaline back a bit, because you're on a vasopressor dose of adrenaline and you might be able to get that down a bit and improve things just by doing that.
And that's the key bit here, isn't it?
Tachycardia as well.
There's 2 approaches to intensive care. When you create a problem with one of your treatments, you can add another treatment in to fix the problem. And when that creates a problem, then you add another treatment in to fix it, or you think, can I take away the treatment that's causing the problem? So we can dilate our patient by turning our pressors down rather than adding in another drug, because we're happy with our function. We don't need any more inotropy. And milrinone's it's a good drug to use where you need to, but it's slow to act. And once you've started it, it's a long half-life, so you're not going to be able to turn it off that easy. And just turning the drugs that are too high down is probably what we need to do for this patient. So we'll go ahead and wean our adrenaline down to 0.2, NORAD down to 0.3, and with that the heart rate falls, the blood pressure improves to a more normal level. CVP drops as we've widened our space, so the amount of fluid that there is appropriate for the space, and with that we're now starting to perfuse our organs. Our venous sats improve, they're not too far away from our target, and our lactate starts to fall. You'll probably notice an improvement in the venous sats before the lactate, and our patient is starting to warm up out to their knees and elbows. And at that stage, the paediatric retrieval team arrived to pick the patient up. So in summary, I think the key learning points are, before you intubate one of these kids, make sure you start your peripheral adrenaline and make sure to reach the patient before you induce anesthesia. If you don't, you'll be doing CPR. Remember, the goal is to restore cardiac function and afterload and filling to normal. So when your patient isn't improving, don't just keep turning the vasoactive drugs up, because as you see in our patient, that's the wrong strategy. Remember, don't forget about your calcium and your steroids. I think out of all the big list of problems, they're the two big ones. And the things that I like to monitor are particularly your lactate and your venous saturations as a marker of improvement. If they're not improving as you resuscitate your patient, you need to ask yourself why. And you should definitely be phoning the paediatric retrieval team when we can discuss this through with you and work through the case with you to see what we need to do with the patient.